ahead and get started. Welcome everyone to our presentation today, to this installment of Voices from the Field. Today we have the pleasure of meeting with three incredible speakers who have made a significant impact on critical care nursing in Malawi. So I'll briefly introduce our three speakers and then get into the questions. Our first speaker, Wezzie Mwafulirwa, is a critical care nurse specialist at Queen Elizabeth Central Hospital in the Adult Intensive Care Unit. Wezzie earned her master's degree in nursing intensive care from Witwatersrand University in South Africa and boasts 18 years of dedicated service to the Malawi government and 9 years specifically in critical care nursing. Before assuming the role of critical care nurse specialist in 2023, Wezzie served as the ICU's principal nursing officer since October 2019. And as a critical care nurse specialist, Wezzie now leads the ICU team, focusing on developing and delivering comprehensive quality and specialized nursing care, grounded in the 5 core concepts of nursing, which are direct patient care, patient and family advocacy, education and training, collaboration, and research. Wezzie champions a united front within the ICU. She firmly believes in the power of teamwork to solve the toughest challenges. Her commitment to building an inclusive workforce is evident through active participation in the ICU working group, ensuring that the team reflects the diversity of the patients served at Queen Elizabeth Central Hospital. Jennifer Duran is our next speaker. She has dedicated almost 30 years of her nursing career focusing on caring for laboring women and critically ill newborns. Early in her career, she was drawn to the complex needs of pregnant families and critically ill newborns, actively seeking opportunities to enhance care through education. With over 2 decades of experience at the bedside, as a bedside nurse in the newborn ICU at Massachusetts General Hospital, Jennifer is a valued member of the NICU team, providing dedicated care to critically ill newborns. Dr. Duran, a faculty member at MGH Institute of Health Professions, is also the clinical learning lab coordinator and is committed to improving health outcomes in low resource settings through education. One of her proudest achievements is the creation of the Bubble CPAP device for newborns designed to enhance neonatal mortality rates through rural Ugandan nursery. This device, not reliant on electricity, addresses a critical need in areas where power is an unreliable source, significantly reducing neonatal deaths following its implementation. Jennifer recently completed her doctoral work focusing on quality improvement, assessing the impact of simulation education booster sessions for novice pediatric intensive care nurses, specifically regarding the delivery of chest compressions to pediatric patients. This impactful project is anticipated to enhance nursing education strategies. Her work in Malawi at Queen Elizabeth Central Hospital this summer builds upon the foundation laid by these education projects. And with this wealth of experience and commitment to improving healthcare globally, we're honored to have Jennifer with us today. And next is Leah Rothchild. Leah is a registered nurse and a pediatric nurse practitioner student at the MGH Institute of Health Professions. She's been recognized for her leadership and dedication to patient care and advocacy. Leah represents the state of New Hampshire as a graduate nursing student advocacy leader and is passionate about reducing the stigma associated with mental health diagnoses, expanding access to comprehensive health care, and global nursing. Leah is a strong supporter of the Physicians for Peace mission to teach one, heal many, and looks forward to future opportunities to continue building cross-cultural professional relationships to collaborate on innovative solutions to complex health problems across the globe. So Wezzie, Jennifer, and Leah began working together earlier this year and completed a 3-week assessment and educational course based on topics that Wezzie and her team have prioritized to improve the skills and confidence of the team to provide excellent care to medical and surgical patients in the ICU. We're excited to welcome Wezzie, Jennifer, and Leah to today's discussion and look forward to gaining valuable insights from their experiences. So for our discussion today, if you have any questions during the presentation, please do use the raise hand feature in Zoom and we will call on you. Or if you would prefer to type your question into the chat, then we can address those at the end in our Q&A session. So without any further ado, we'll start with our first question, which is for Wezzie. Wezzie, could you share some of the notable successes or highlights, things that just kind of stood out to you while collaborating with Jennifer and Leah and the student nurses that came with them over the summer and working with the ICU staff?
Thank you so much, Leslie. Just to mention maybe just a few things. Yeah, there were so many things that I saw that this training actually tried to help us as ICU nurses, and also even with the collaboration that we have with the PFP. One of the things that I saw was the confidence that the nurses, got after the training. You would actually see that I think maybe in the very first beginning, the team that we had, it was comprising of both experienced and non-experienced nurses. And for those non-experienced nurses, we would actually see that after the training, the questions that they were asking and the skills after the practical sessions, the skills that they had learned after the training was actually something that they appreciated, and you could actually see the changes, and they started even implementing, because the way the training was designed, we had a little bit of theory and more of the practice, and you could actually see them, even saying it and doing it confidently, and that was actually outstanding. And then another thing that I actually, appreciated was the talk about communication. When you work in critical care units, one of the things that is very, very paramount is teamwork. And the way you communicate can actually help maybe to at least maybe put down some other things that that are necessary in the patient care, or maybe raise them up. So we talked about this through the discussions that Jennifer and the team brought in, and it actually helped us to see that it's something that we really need to look into, and we need to practice in a way that when we are communicating, we should be able to bring in, the positive effects that will actually help in the patient care. I think just to mention a few, I would actually say this.
That's wonderful. Thank you, Wezzie. That's so interesting to hear about some of those soft skills, could be referred to as soft skills like communication, and how impactful you see those from your point of view. So thank you. Jennifer, I wonder if you could share specific instances where you observed improvement in critical care practices or outcomes as a result of training, and maybe even to go back to the objectives of the training that were discussed collaboratively before the in-person training, and then how those objectives were carried out, and the improvements that you saw.
Yeah, it was really great leading up to our 23 days together. We had spent some time through technology communicating with Wezzie, also with another nurse educator, Ina, who I see on here. Hello. It was just really great to get to know each other and build that rapport through technology before we were able to work together. And then we got to work for 3 weeks, and it gave us an opportunity to really get to know one another and work on our communication styles. In that time, I was able to see the confidence of the nurses really soar. Thinking back to our first day teaching, it was quite quiet, which can be a little nerve-wracking, but by the end of our 3 weeks together, there was a lot of laughter and fun and a lot of exchange of ideas. So it was really awesome to be part of that. One of my favorite moments was our CPR training, and it can be a little hard to make CPR fun. It's a pretty serious skill. We're resuscitating patients. We're attempting to restart their heart or their breathing efforts. But we decided to focus on teamwork and communication. So we picked up about 10 or 15 songs that matched the beat of the compressions that we wanted the participants to demonstrate, and it was wildly successful. So that was really fun, and I really loved watching how everybody was really silly with each other because their work is quite serious. Another example was on our last day, I believe, we focused on ventilator management, and it's a pretty high level interactive session that we had a very long discussion over several hours. And this is where the group really had an opportunity to shine. We spent hours walking through respiratory conditions and how to manage them with different approaches using ventilators. We used case studies, question and answer sessions, as well as visuals. The open dialogue throughout the didactic session really made it evident to all of us just how much knowledge the participants had and that they were able to grow over time. You could really see the pride in their faces. So that was really great as an educator to witness the students naturally becoming the educator. We did not have to stand at the front of the classroom and necessarily just lecture. It was more an open dialogue, and we were kind of guiding each other through the content. So it was really awesome. It was as if, the educator torch was being passed, from us onto the home team, and they just willingly took that and ran with it. It was really great.
That sounds wonderful. Thank you. So by way of context, I think it's important to also add that, how we came about this collaboration was in learning and understanding the needs of the ICU, as previously stated, and particularly in having grown the ICU from 4 beds to 12, and all of the nurses who, as Wezzie spoke about, were of varying levels of experience. And so that was kind of the need for the training that was established early on. So I want to ask this next question to Leah. We often learn from challenges, and just wondering if you could speak to some of the challenges that you encountered during this training, and how did you work together to overcome them?
Yeah, that would be great. If we could just advance one more slide. Thank you. So I think really the greatest challenge was going back home. For anyone who doesn't know, Malawi is known as the warm heart of Africa, and it really lives up to that. It was really difficult to leave after being immersed in such a rich, welcoming culture. But while I was there, I think the greatest challenge was determining what the local ICU team identified as challenges. And this is what Leslie was just talking about, that we didn't want to come in with our ideas for education. We certainly had some ideas, but we really wanted to get a feel for what is the need here from the local perspective. And I think it's really important to remember that in healthcare and nursing in particular, there's this balance between an art and a science. And so when it comes to the science portion, things are pretty black and white. Like if a patient is bleeding, we all agree we need to stop the bleeding. If someone has a broken bone, we all agree we need to stabilize and rest that area. But then there are the things that are more related to the art of nursing, and these are more subjective, and it's the nuanced care that we provide that differs based on patient needs, available resources, or even just a particular nurse or the cultural context in which we practice. And so I think in the context of this trip, when I first entered the ICU, I saw a lot of things that look quite different from what I'm used to seeing here in Boston. And so the challenge was pausing to ask myself, is this a difference of art or a difference of science? And if it's a difference of art, then why does this different approach work best in this context? And how can I adapt kind of my expectations and my teaching to meet this? And so before offering any suggestions or education, we wanted to learn. So we spent a week just observing and asking questions. And this was, along the lines of, what do you see as the biggest challenge? What are the most significant barriers to patient care? Why do you choose to do that in this particular way? And really just trying to understand how things work and why they work. And one of the differences I noticed pretty quickly related to medication administration. And this is a topic that I'm very passionate about. And where I practice in Boston, we have very, very strict rules about how it needs to be done. So all medications have to be locked up. We have to verify a patient's identity in several ways, including electronically scanning a barcode on a hospital bracelet. But at Queen's, they don't have electronic records or scanning devices, and the medications were often kept at the patient bedside. And so when I first observed this practice, I had red flags that went up because it's so different from what I'm used to. But it wasn't seen as a problem in the cultural context of Malawi. And so it was really important for me to inquire about that and learn about it, and then adapt my presentation to fit what works in this cultural context. And so when I asked about the practice of keeping medications at the bedside, I learned that they had actually tried storing them in the back, and it led to challenges where multiple vials of the same drug would end up opened at the same time, which would contribute to waste. And so it really is so important to understand why things are done differently. And just keeping an open mind and being willing to learn from the nurses there allowed me to really reframe my thinking and teach material in a way that was contextually appropriate. And as you can see from the picture here where I'm teaching medication administration, I had a blast doing it. And I think everyone else enjoyed it. I like to think so. And then shifting gears, Wezzie touched on communication and teamwork a little bit earlier. And that was the other topic I wanted to address here. And I just love that other picture on this slide. That is Livia, one of the nurses during Jennifer's CPR training, and her hair was getting in her face, and a colleague quickly jumped in to pull her hair up for her and help her out. And so I just love that picture as we segue into teamwork. But if we could just advance one more slide. So communication was something that was actually brought up to us when we first got there as something that they thought needed improvement and was a challenge. And so we noticed that there was excellent camaraderie, and everyone wanted to support each other, but there was not always clear communication. And so we did this really fun team building activity called the Human Knot. And I will briefly explain what that is. That's what's going on in the top left picture and the center picture on the slide. So we all stood in a circle, and everybody put their right hand in and grabbed the right hand of somebody else. The only rule is it couldn't be the person immediately to your left or immediately to your right. Once everyone's right hand had another right hand, we repeated it with our left hand. Same rules, but the additional rule is that it cannot be the same person that you were holding with your other hand. And so once everybody does this, you can imagine it's a big mess. Everyone's arms are kind of all tangled up and twisted around, and we're all mashed up against each other. And the goal is to try to untangle and form just an open circle where everyone is holding hands, but you cannot let go of hands during this process. So there's a lot of stepping over arms, ducking under arms, crawling through tunnels made of arms, and it gets really silly. We had a lot of fun doing it. There was a lot of laughter, and we had two teams going simultaneously. My team was really struggling to untangle. We really hadn't made any progress. And suddenly the other team started cheering and celebrating really loudly. And so we were at the standstill now because we couldn't hear or speak over the shouting. So we ended the activity and had a debrief session. And first we talked about what contributed to the success of the one team. And they identified clear communication, that initially there were multiple voices all kind of calling out, but this quickly transitioned into one person self-identifying as a leader and taking charge and giving clear directives to the team. And then we discussed what did not work so well for my team. And we heard that really it was the same thing, but the opposite, that there was no clear leader. There was a lot of hesitancy, not a lot of kind of coming together and working on the shared goal. There were people untangling on the left side and the right side of the circle at the same time. And so then I used that opportunity to ask what happened when the noise level went up in the room. And the nurses in my group identified that they weren't able to communicate over that noise. And so then I asked, do you think this noise level ever contributes to communication challenges in the ICU? And there was a lot of laughter, and they admitted that the noise probably does hinder effective communication sometimes. And so this facilitated an introduction of a concept that's gaining popularity here right now. There's been recent research about benefits to patient outcomes in ICUs when there's mandated quiet hours for certain parts of the day. And so not only does it facilitate that increased rest and rehabilitation for patients, but it also allows better communication. And so I had noticed this noise level difference on my first day of observation, but had I come in on day one and suggested implementing quiet hours, it would not have been accepted because it wasn't consistent with the current culture there. And so using this type of activity served as an icebreaker and allowed us to be silly and have fun and build effective communication. But then we were also able to use the debrief as an opportunity to translate these skills into patient care and see how that can really make an impact. There's also some photos on this slide from a different team building activity that we did that was really fun, which I'm happy to talk more about at the end if there's time. But for now, I'm going to just share the time.
Thank you, Leah. It sounds like you didn't have any fun at all. And I really love that perspective of, coming in with a fresh perspective and being curious and remaining curious and just seeing what unfolds. And a lot of times that could be rather surprising what unfolds, which leads me to my next question. For all three of you, we could maybe have you answer one by one, starting with Wezzie. But what would you say surprised you the most during this time together in Malawi, from maybe a volunteer perspective, from a clinical nurse educator perspective, from a leader? Just what was the most surprising to you?
Okay. I think the way the trainings were actually designed. I've been involved in most of the critical care trainings in our country, and I would say this was one of the more, a different, kind of training, in such a way that there was a lot of interaction, and there were some things that were just being maybe added to try and motivate, the participants to be active. And we saw that the participants were fully active in all the sessions. I've been to some, trainings where you see people dozing when they are maybe being taught about something, but this wasn't the case. And another thing is, the way the team managed to, bring in some things that were quite relevant to the particular, topic that we're discussing, that would actually remind the nurses to use it, and also maybe remind the nurses to actually maybe apply when they are actually working with the patients. So I found that quite, catchy, and also I learned something from that. Yeah, maybe just to start.
Thank you. Jennifer, what was surprising to you?
So I think one of the biggest surprises to me were how many resources were readily available to the ICU staff. They were blessed enough to have many ventilators, IVs, and medication pumps, other life-saving devices. And this discovery really solidified for myself, Leah, and our team, our group's belief on the impact of nursing education and how this could truly impact patient outcomes. So we spent our efforts over our time at Queen Elizabeth, not in solely providing supplies to the staff, but rather in offering educational support to help elevate their practice. And so that felt really good. We spent many months preparing ahead of time. I think there was a total of 35 educational sessions between didactic sessions and skills sessions. And so we had so many physical resources to work with, and we just really wanted to help empower the nurses through education.
Wonderful. Thank you. Leah, how about you? What was surprising?
I think I was most surprised at just how welcomed and embraced we were immediately. In my past global health work in Uganda, Jennifer had already been there twice and built wonderful connections. So I wasn't sure what it would be like to be building brand new relationships in Malawi where we hadn't laid any roots yet. Of course, we had spoken with Wezzie virtually, but it feels so different to arrive. But I never felt like a stranger or an outsider in their ICU. The whole team was just so gracious and so warm and really welcomed us from day one.
Yeah, I remember you both commenting on that in the early days of the trip. And just as a reminder, this project builds on the Physicians for Peace relationship with the hospital since 2011, working in surgery education and working in the pediatric ICU and now in the adult ICU. So it's so gratifying to hear that. And of course, we had no doubt because Malawi is the warm heart of Africa and lives up to that title very well. But I think that also facilitated maybe the success of some of those team building exercises as well. You didn't feel like an outsider for very long once you got there. And so that's really wonderful and very important in building sustainability, which is our next question for Wezzie. We know that building sustainability is crucial in education and in trainings if you're looking at outcomes to improve patient care. So I'm wondering if you could tell us about strategies or ideas that you have for maintaining the momentum and ensuring ongoing training for the critical care nurses in your unit and your team.
Yeah, I think first of all, it's I think something to do with networking, just to make sure that we are strengthening the bond. And this is a collaboration between the facilitators and also the critical care group, the whole group. We have started with maybe a WhatsApp group. We have created a WhatsApp group. We want to be posting updates just to make sure that we keep in touch. And maybe Jennifer, Leah, we are planning to also have another session next year early. And yeah, I think we'll discuss that after this, maybe sometime in this month. And we really want to have ongoing trainings on that one. And in the course of the training, what we want is to maybe identify some champions or mentors that can maybe coach the other nurses. It could be, maybe we'll see how they are performing maybe through the trainings and maybe with the ongoing supervision. And then we can give them certain roles regarding the areas that we are focusing on, like, for example, just looking at patient assessment. Somebody who is a champion on that area can actually be selected to mentor the others. And maybe just to add on that, we have a program, an induction program that is just started a year ago. We are trying to maybe orient the new nurses, and we believe that if we can have this networking maybe process, that means we can also co-opt Jennifer, Leah into the group that we create for the new nurses, just to assist, so that at least at the end of the day we have a well-trained ICU nurse who has been oriented on bedside. I think this is just to mention a few. Thank you.
Thank you, Wezzie. My next question is for Jennifer. In your view, what would you say were some of the most significant strengths and unique qualities of the nursing staff, and how do you think about using these strengths, leveraging them in future training initiatives?
So I have to say, I was pretty humbled by the true generosity of spirit extended to myself, Leah, and our group. Each team member, from the moment that we joined at Queen Elizabeth, welcomed us not only with their words, but in their actions. There were many smiles and hugs, and including us on the rounding process. So immediately we felt like we were part of the team. And it is very vulnerable, to be that outsider, because we want so much to be part of the team, and the home team made it known that we were welcome and they were going to include us right away. So that was really great. So they welcomed us with hospital tours and observational experience. And Leah had talked about that this first week was really crucial because it allowed us to ask a lot of clarifying questions and to observe. And we reminded each other that we were not going to provide any patient care, and we were not going to provide any direct feedback to the nurses that we were observing, but we were simply jotting down notes and asking clarifying questions. So it really allowed us to get to know the home team really well that first week. And I think it's an incredible asset to any team to be so gracious with their time and their efforts. And it really did inspire others to rise up and do the same. And we saw a lot of progress in that over time. So I think that was one of the most significant strengths of the home team at Queen Elizabeth.
Wonderful. Thank you. And I have one final question for Leah, and then we will open it up to questions and answers and anything anyone wants to share. So Leah, what lessons have you learned from this project that you believe could be valuable for other healthcare initiatives and resource poor settings?
I think for me, really, this trip reinforced the foundations of global health work and cross-cultural interactions overall. First and foremost, that it's okay to have different opinions and to celebrate different opinions and values. Kind of having these conversations, hearing about different opinions, different ways of doing things is how we learn and grow. And that is a two-way thing. And, I think that's really important with all of these trips is that it is not with the goal of being a one-way flow of information. It's not about me or Jennifer coming in as the holder of knowledge. It's really about facilitating the exchange of culture and knowledge and beliefs, both directions. I think going with the mindset of being a learner and not a teacher, which really kind of builds into that idea I was just talking about, leading with curiosity, asking those questions, really making an effort to understand why things work within a cultural context before trying to change anything. And then remembering that it's really not about what's right or wrong in practice. It's very subjective, and it's really about what is or isn't working within the current system. And that approach really allows us to exchange these ideas and improve both of our healthcare systems simultaneously. Finding joy and spreading joy in every situation is a big one for me. As you could see and hear from the pictures and the activities I talked about, I really love to have fun, and it's really important to me to have fun and to try to bring other people into the fun. So we did a lot of laughing. And then one of the things that really stood out to me that I learned from one of the participants in a debrief session after one of the trainings, she said, "Knowledge is power, and we've been empowered." And I think so many other global health organizations focus on donating equipment or supplies, but that's not, oh gosh, the lights are going out, sorry. That's not what Physicians for Peace is all about. And so with that teach one, heal many motto, they're in the business of sharing knowledge and empowering people all over the globe. And that really is the best approach. So remembering that when we share knowledge and not equipment, we are building empowerment that can stay within a country and be shared beyond that area, and continue to empower people long after we leave.
Sorry, I was muted. Thank you for that, Leah. That's very wise indeed. I love to hear those wrap-ups and staying curious and learning as we go. So thank you for that. So now we have time for questions for anyone who is here with us today who wants to share any insights. Or if not, time for another story. I don't see any questions.
No questions, but I just want to be you. It sounds like a great, it sounds like a learning on steroids. So I really appreciate these stories, and I would love to hear more, actually.
I'll just make a comment here on the slide that we currently have up. Leah is one of our trusted educators, and in both of these photos, she's here as a vulnerable participant. And I think that really helped with capacity building. Some of the skills that we were working on with the nurses were auscultating lung sounds and assessing blood pressure. And I remember watching this and taking this picture and kind of seeing the surprise of the participants when Leah sat down and moved her sleeve up, like, check my blood pressure. It was a little bit surprising, but then you could just really see the group really, needing together. And it was really awesome. And the picture on the right, she was leading this educational session, but she was actively listening to the viewpoint of the ICU nurses. And again, it empowered our education sessions because it gave us more information, and we weren't always right with our first observation, and we had to remain humble in that.
Mm-hmm. Yeah, I wondered too if it might be helpful for any of our speakers to go over some of the skills that were taught. We mentioned that these topics came up as priorities that Wezzie and her team identified, and we work in a partnership model. As well, we were able to partner with our colleagues from Norway. The University of Oslo Hospital is also supporting the unit. And so we were able to work collaboratively with them to help identify kind of strengths and weaknesses and where Jennifer and Leah and the team might readily focus on during this first trip. But would any of you like to kind of share some of the topics that rose to the top that you focused on during the trip?
Sure, I can jump in. We designed 35 education sessions. So some of the things I have a list, ambu bag and resuscitation, that was really impactful because in the ICU there was lots of resuscitation opportunities. So this was an opportunity for us to assess their practice and make recommendations to improve their skills. Vital sign assessment, interpretation, and management. We did this through the rounding process, and we also did this with case studies, which I think was really interactive and helpful for them to work through each of the case studies. IV management, Foley catheters, tracheostomy. They have patients with tracheostomies. Hand hygiene. It may seem pretty base, even with our students, we kind of get some grumbling and eye rolls. Like, of course I know how to wash my hands, but we had this really great educational session and we didn't fully explain that we were going to be using this germ gel. When they realized that we had these, lights that were going to be inspecting their hand washing, I mean, the room just erupted in laughter. And again, it made us all vulnerable to see, like, I make mistakes too. How can I make improvements? Medication administration. Leah is so passionate about pharmacology, and her and I both were a little worried about this high level education, and we weren't really sure how it was going to be received, but it was so interactive. I don't know if you want to comment about that, Leah. That was definitely your big baby there for sure, and it was very successful.
Yeah, it was a lot of fun. And I think what made it fun and not quite as rigid as that topic can be is that I really wanted to continue learning about the cultural context and the current practices throughout the presentation. Having that 1 week of observation didn't give me all of my answers about it. So rather than getting up, I focused on the 6 rights of medication administration, which is something we talk about here, where you're verifying that it's the right patient, the right medication, the right dose, all of these things. But we have very strict protocols for how it's done. So I didn't want to just get up and say, and first you do this, and then you do this. But rather, when I got up to talk about right patient, for example, it was, how are you verifying your patient? What is the system here? Is it working? Do you have concerns? And if there weren't concerns, then we would kind of move on, because I'm not there to change current practices if they're not seen as problematic. I really just wanted to support the needs that were identified from the local team. I think the vital signs also that Jennifer had mentioned, that was a really big one. And that was a training we had not planned on doing ahead of time. We thought that the requested training was really going to be more things like CPR or resuscitation, tracheostomy care, more of these intensive care specific things. But what we saw in our observations is that there was a lot of reliance on the equipment. So it was automated blood pressures, and whatever the machine displayed was kind of documented without question. And all of these nurses were so dedicated and bright and motivated and capable. And so really it was saying, does that blood pressure seem consistent with the patient's history and current presentation? And if not, how can we investigate to see, like, is this a problem with the machine? Is this a problem with just the way the cuff was put on the arm? Can we verify with a manual blood pressure? And so kind of building those critical thinking skills of how can we troubleshoot and problem solve, but also taking the time to practice those fundamental nursing skills of doing a manual blood pressure, taking like a radial pulse, listening to an apical pulse, or listening to lung sounds, all of these different things that, you know, had been taught in their school program, but had not necessarily been implemented into their care. And so it was that refresher for them, building those skills and then working on integrating the critical thinking.
So as if pharmacology was not a big enough risk, Leah really stretched herself and decided to add mindfulness to the training. And this really was probably the greatest risk and reward of the trip. If you want to talk about that, Leah, I thought this training was awesome.
Sure. Yeah, so mindfulness is a topic that is kind of difficult to talk about even here. We've got people that are really, really big fans of it and big supporters and believe fully in it, and a lot of people that think that it's kind of a load of baloney. And there is a lot of data to support that it's effective. And so I didn't want to just kind of come in and say, like, we're doing mindfulness today. So we eased into the topic. It was part of a pain management presentation. And so we started with using like verbal pain scales. And then because this is an intensive care unit with a lot of intubated patients who are sedated, unable to speak, we talked about using nonverbal pain scales and how to assess grimacing and body movements and all of these things to determine, is my patient experiencing pain? And then we moved into traditional pain management with medications, and then some of the more traditional non-pharmacological interventions. So that would be things like using heat or cold or elevation, things that are pretty widely accepted. And then the last little shift was, and here are some mindfulness activities. And I really wasn't sure if I was going to be laughed out the door for this topic. But I actually, one of the nurses, I overheard her in Wezzie's office after saying that she wanted to be like the self-identified champion of mindfulness and self-care. So I know at least one person fully bought into this. But it was really great because we talked about how we can use it for the patients as well as how we can use it to care for ourselves, because nurse burnout is a real problem globally. And there are nursing shortages in Malawi. And so really, it's so important that we take care of ourselves so that we don't lose the nurses that we have. We need to keep people mentally and physically healthy. And so I had a lot of fun introducing that topic. And Wezzie, I don't know if you want to jump in on anything, but I also think Jennifer should talk about her CPR. What did we call it? Compression karaoke, I believe.
Yes. This was another skills training session that just naturally evolved when we were there. We wanted to do some resuscitation training that's expected when you're working in the context of an ICU. But then we just decided, let's make it fun. CPR is not too fun. And I just, kind of want to elevate everyone's practice. So we were able to look up about 10 or 15 songs that matched up perfectly with the compression rate. And I think Leah and myself probably had a little bit too much fun during this resuscitation training. But I do believe that attitudes are contagious, and everybody was just having a really good time and able to offer each other feedback in a really safe space, like, hey, let's pick up the pace. And we were able to sample lots of different music as well. So that was a really fun day. So again, we weren't sure if our teaching approaches and methods were going to be well received, and that's always such a risk, but big testament to the team and how open they were and welcoming to us.
Wonderful. Well, thank you for going through all of those different topics and details. I think there's so much that we can learn from you sharing your experiences, maybe almost as much as you all learned being actively involved in them. So if there are no further questions or comments, I think we will go ahead and wrap up just a few minutes early. I want to thank everyone who is able to join us today. These are the different ways that you can connect with us on social media and on the just in general, that we talk about all of our projects. We have a few blogs up on our website specifically about this training, including one that was written while it was taking place. And we always appreciate support, financial support. That is very important to everything we do. Everything costs money, and we're very blessed to have dedicated volunteers like Jennifer and Leah and the team who volunteer their time. But there are a lot of other costs involved in carrying out training, both in person and remote and ongoing. It's part of our sustainability model. So I just want to thank everyone again for your time and interest in this topic. And thank you for all of our partners and family members and team members here with us today. We hope to connect with you in the future and be able to provide some updates on this great work. Thank you, Wezzie, Leah, and Jennifer, for sharing everything with us today. We really appreciate it.
Thank you. Great to
Thank
see
you.
everybody. I see a lot of our colleagues.
Thank
Great to see you.
Thanks, everyone.
Bye-bye.
Bye-bye.
Bye.
Bye-bye.